To today's webinar. Hello, everyone, and welcome to today's webinar on preparing to serve migrant and seasonal agricultural workers and other vulnerable populations through public health emergencies. We're glad to have you here. We are going to go ahead and get started because we've got a lot of great content for you and a great set of speakers. So I'm just going to go ahead and dive in. So before we jump into content, I just wanted to cover a little bit of housekeeping. All participants are muted upon entry to limit background noise. So please keep yourselves muted throughout the presentation. Feel free to use the Q&A or chat box to ask questions during the session. We are going to be reviewing Q&A at the end of the session today to make sure we have time to hear all of the speakers. But please note we are keeping track of that and we will get to your questions at the end. This webinar is being recorded and the materials and recording will be emailed to participants afterwards. We are also going to be sharing this recording to the HRSA Health Center Clearinghouse, so you should be able to have access. And then finally, we'd love to hear your feedback, so please stay till the end and fill out our brief evaluation. It takes a few moments and it really does help us ensure that our content stays relevant and we listen to everybody's feedback for future sessions. So before we jump into the content, I just wanted to briefly introduce MHP Salud. We're a national nonprofit organization that implements and runs community health worker programs. These programs provide peer health education, increase access to health resources, and bring community members closer. MHP Salud also has extensive experience offering health organizations and service providers training and technical assistance on CHW programming tailored to their specific needs. We've been around since 1983, and we also are a national training and technical assistance partner funded through HRSA. And we offer federally qualified health centers and lookalike organizations resources on emerging issues related to migrant and seasonal agriculture workers and their families, technical assistance on how community health workers or CHWs improve health outcomes for MSAWs, and learning opportunities on how health centers can integrate CHWs into their clinical care teams. For more information about our organization, please feel free to check us out at mhpsalud.org or email us at ntap@mhpsalud.org. My name is Shannon Patrick. I'm a health strategy specialist here at MHP Salud, and I'm going to be the moderator for today's session. My colleague, Monica Calderon, is a certified CHW and a CHW instructor, and also a health strategy specialist here at MHP Salud, and you'll be hearing from her throughout today's session as well. And with that said, I'm going to jump right in and introduce our first speaker. Our first speaker is Harley Jones. He's the Senior Manager of Domestic Emergency Response at Project Hope. He leads a team of medical professionals and volunteers in projects across the United States. And as an emergency management professional with over 15 years of experience, Jones is skilled in crisis management, program development, and program evaluation. Prior to joining Project Hope, Jones was the Chief Executive Officer of 360 Youth Services, a nonprofit organization providing life-changing services to youth through prevention, education, counseling, and housing. He also served in multiple roles at the American Red Cross, most recently as the Regional Disaster Officer of Chicago and Northern Illinois, where he held teams on preparedness, response, and recovery for a community of over 9.5 million people. Jones has a Master of Arts in European History from Illinois State University and a Bachelor of Arts in History from Eastern Illinois University, and post-college, Jones served in the AmeriCorps, responding to disasters around the country and educating over 15,000 individuals on life-saving skills. Welcome, Harley, and I'm going to pass it to you.
Great, thank you, Shannon. Can you hear me?
Yes.
Excellent. Thank you so much for the introduction and reading the bio. Just a huge thank you to MHP Salud as a partner for having us here. Most interesting, just not only kind of pointing out my background from the American Red Cross and just letting you all know that since 2004 have spent probably about 100 days a year at various disasters, and I spent 2004 in my first hurricane season in the state of Florida, and have been back many times, not only with the American Red Cross, but both as a volunteer as well as leading volunteer teams in emergency response with Project Hope. I came to Project Hope in 2020 during the pandemic, in which I started and kind of kicked off my work in the public health sector by leading our pandemic response across the United States. So more than anything, I kind of grew up in the emergency management world, and I'm really excited to spend this part of my career targeted at and working with not only vulnerable populations across the United States, but with clinics, fairly qualified health centers, as well as free and charitable clinics across the United States. So thanks for having me. Disaster is something I've spent a lot of time doing, and I'm excited to share some of that with you, as well as our passion around serving vulnerable populations. And I'm really excited to have a couple of our clinic partners today talking about their own experiences post-disaster. So can you go to the next slide for me? Just a really quick snapshot about Project Hope. You may or may not have heard of us before. I know we probably worked with some of you post-disaster and even in some of our work with HRSA and other groups. But Project Hope is a global health organization. We've been around since the 50s. You may remember the hospital ships that popped up in the 1950s and 60s, went around the world, the USS Hope, the USS Comfort. Those were started by Project Hope's founder in the 50s and 60s. Since then, the US Navy has taken up those ships, and Project Hope has transferred into kind of a global health organization on the ground in 30 plus countries around the world, including here in the United States. You can see our mission and vision there. But at the end of the day, our mission is all about empowering local healthcare workers. And so we do that through a variety of different methods. Next slide. Great. So just a couple of ways that we work with frontline healthcare workers around the world and here in the United States is that we are targeted and focused at empowering local healthcare workers, clinics like yourself, who are caring for the most vulnerable populations in the United States. That's core to our humanitarian work, it's core to our humanitarian mission, and we've done that in various forms around the world and here in the United States over the course of the last few years. In particular, post-disaster, we have teams of volunteers and medical professionals on the ground post-disaster, in particular, providing support to clinics and primary care providers when that disaster is impacting their work and the livelihoods of the individuals that they serve. You can see we spend a lot of time in the area of pandemic and public health preparedness and response, as well as working on things like infectious and non-communicable diseases, maternal and child health, and of course, health policy across the country. All right, next slide. So a couple of minutes, or just give you a quick snapshot of what we're going to talk about today. And the other thing that I want to acknowledge from all of you is thank you for sharing. When you registered, you were asked a couple of questions around number one, kind of the pre-existing health concerns that you often have in working with the MSAW population. And so we took some of that into consideration as we were thinking about the things to talk about today. But also you did talk a little bit about some of the training needs that you see for your frontline healthcare workers, including community healthcare workers. So we'll bring that up over the course of the conversation as well. So first, we're going to talk about just the importance and some of the requirements from our perspective and what HRSA expects of clinics as it relates to emergency disaster preparedness. We're going to talk a little bit about kind of the unique challenges of serving the MSAW population. Not anything you really haven't heard before, but we'll put a little more focus on that from an emergency response and preparedness perspective. We'll talk a little bit about some kind of high-level components of disaster preparedness and planning. We know and understand that as primary providers and as clinics, you spend a lot of your time focused on providing care to the individual patients that you serve and their families. Don't always have the time and the wherewithal to go to additional disaster training or do emergency management in the same way. So we're going to talk a little bit about those. And then we'll round out the presentation and kind of finish up with not only continuing to highlight some of those challenges and potential solutions around them, but also opportunities for training and education for your staff members, and then understanding the disaster environment when something bad does happen in the places that you serve. You're going to know a lot of this. I'm going to talk a little bit about how to potentially navigate some of those things in some places where it makes sense for you to plug in and not plug in, but also know and understand you all have a lot of experience with that And will probably know as much about that in your local area as I do, because as everything is in the United States, everything looks different depending on the jurisdiction, the city, the county, the state that you live in, and is going to look different to each and every person. We'll finish up with a couple of slides before we get to some of our clinic partners, including a couple of high-level resources that we'll point out that are always out there for you and your clinics. Next slide. So really quickly, one of the most important things that we do in thinking about disaster emergency preparedness and planning is just kind of identifying and thinking through the kinds of emergencies and disasters that we might face, right? This is completely different depending on where you are, where you work, and where you live. And for those individuals, those MSAW individuals that we're thinking about today, those migrant and seasonal agricultural workers, this is going to include a whole set of things that we might not think about on a day-to-day basis, which of course is related to the agriculture environments that they find themselves in, right? Or construction or hospitality or manufacturing. And while we're talking about MSAW populations in particular, knowing and understanding that just because one of those family members works in the agricultural sector, other members of their family might work in some of those other places. And it's important for us to keep an idea of what's going on with those. So you can see a list of natural disasters here, right? These happen all the time. Where many of you, I'm sure you're more experienced with hurricanes than anybody else. I've had the opportunity to respond to things like hurricanes across multiple states across the US, and know and understand that they create a unique set of challenges. Of course, I think we were reminded just a few days ago that sometimes disaster and emergencies are man-made. I thought about this presentation and the conversation 2 days ago when I watched the ship run into the bridge in Baltimore just 2 days ago, and knowing and understanding that not only did that come with loss of life, right? So the individuals who were missing as a result of that, but now this is going to create a whole system of isolation for often vulnerable populations in those places. And sometimes those man-made disasters can be just as affected as anything else, not only from loss of life and isolation of those communities that the loss of that bridge might bring, but the economic impact that the closing of a place like the port in Baltimore is going to have a trickle-down effect, oftentimes having a bigger effect on those medically underserved and vulnerable populations at the end of the day as well. So just something to keep in mind as you're thinking about what those emergencies and disasters might be for the people you serve. Next slide. I also want to put out front some of the data that you shared with us at the beginning of this conversation. So as we asked you about some of the pre-existing things that you're most concerned about, excuse me, for these populations, this was the list that you all provided for us. And so a couple of things jump out to me about this list. Number one, none of you will be surprised by anything on this list, right? These are the things that you work with on a day-to-day basis. And you can see that it's a mix of, chronic disease stuff, health-specific things, but also half of that list are revolving around social determinants of health. And so none of this will surprise any of you, and knowing and understanding that these populations, these health and social determinants of health concerns are only going to be exacerbated in a time of emergency or post-disaster. And so as you continue to think about those things and in your individual disaster planning, this becomes a checklist for you, right? So if you know that that family members are dealing with diabetes or hypertension, as well as poverty and food insecurity, you know and understand that a part of that planning that you do from an organizational perspective needs to include questions and opportunities to think about how they are planning for, or if they're prepared, medication, testing supplies, opportunities to gather those things and talk about that with them. Pre and post disaster is going to be really, really important. So again, not surprising with any of these things. It just ratchets up the speed and severity of it when normal systems from a disaster perspective happen. Next slide. So I wanted to start off, many of you know this, but I think wanted to just remind us that from a federal perspective, and oftentimes tied to a lot of the funding from CMS, is this basic requirement that any and all clinics and FQHCs are doing emergency preparedness. So this isn't going to surprise anybody. I put this up just to remind us that this is an important part of some of those CMS regulations. But also knowing and understanding that, we're not going to convince anybody on here that this is more important. You already know it's important. It's important for the people that you serve, but at the same time, it's also an expectation of our national level partners. And so, this presentation is, I think, part of that, right? Helping you think through your clinic's approach to how you're doing emergency preparedness and planning. Are you meeting those basic requirements? And what are the areas we can go above and beyond to think even further about these populations in particular, knowing and understanding how adversely affected they're going to be on the back end of emergencies and disasters. Next. So I also wanted to highlight in particular, maybe some basic definitions and kind of come to a common understanding of when we talk about migrant and seasonal agricultural workers, making sure we know and understand who that population is. You all probably know better than anybody else exactly the groups that you are working with and supporting. And it's going to look completely different depending on where you are, your jurisdiction, the agricultural fields and partners that you have in those areas. But just wanted to kind of lay out some basic definitions here. And so in particular, we're taking this in partnership from MHP Salud. So we're all kind of using a common vernacular. But you can see a definition here for migrant farm workers with a real focus on, those individuals who are working in a kind of seasonal way as well. You can see a definition there. But more importantly, you're kind of seeing the overlap. And we're kind of looking at this population as, number one, working in agricultural temporarily or seasonally. It's kind of funny to use the word temporarily sometimes when it's the same schedule every year for the last 50 years because of the growing cycles. But often that these folks share common language and common culture. And we know oftentimes that many of these will have H-2A visas or maybe undocumented. But this might include people who work in fields, orchards, canneries, plant nurseries, fish or seafood packing plants, or other examples of some of those mobile populations may work in similar conditions. And as I mentioned, they may have family members with them, they may be single, and they may be with groups of people who are working in adjacent industries as well. You can see some of the information there on kind of where we're sourcing some of that info. But according to some of the latest info in 19 and 20, about 44%. I'd be interested to see how, we've got updated data on that. It's the latest we could find, but about 44% of US farm workers from that perspective were considered undocumented in that last study. Next slide. Great, thanks. Once again, from that same study, just some other high-level pieces of data that we know about these populations in particular. I'll highlight a couple of these in particular, but as we know and won't be surprised by, you can see some percentages there, both of how these individuals are identifying, the languages that they speak, and then, of course, some basic demographics on how that breaks down between male, female, married, and children. But a couple of other points that I'm going to make later in the conversation, you can see some really high-level percentages. Things like 83% of farm workers work for the same employer year over year. So a little later in the conversation, when I talk about how you build relationships within your community, I'm going to highlight relationships with agricultural companies or owners as a really important part of this. I know that's not always easy. I know that's not always ideal. But when you look at a number like 83% of those farm workers working at the same place year over year, that kind of relationship can be important in providing you access to the kinds of populations you want to serve. So what makes migrant seasonal agricultural workers unique in a disaster, in an emergency? And so we think about this a lot from an emergency management perspective. I think you already all deal with each and every one of these challenges as you think about serving the medical needs of these populations on a day-to-day basis. And that is a couple of things that we have here, right? Number one, just the rural nature of where a lot of these populations are working, but they're also very hard to reach on a day-to-day basis. We talk to a lot of clinics across the country, a lot of outreach programs that already take either mobile medical units or their individual workers and are going out into the fields that they're working, into the factories that they're working in. And so as you can imagine, if this rural piece is already a challenge on a day-to-day basis as you're dealing with those normal everyday medical issues, it's going to be 2, 3, 4, 5 times harder post-disaster. And so having those conversations in the front end and really working with your patient populations to help them think about those things ahead of time is going to be even more important. Migrant and seasonal agricultural workers are often going to find themselves in closer proximity to toxic chemicals, heavy machinery, accidents, man-made disasters are going to be more likely. And so those are other things that you need to know and understand as it relates to the individual patients and the environments that they're working in. Especially if large segments of your population or the MSAW populations that you work with work in one industry, it's really easy to really get a sense and really dig in to understand what are the specific concerns and preparedness issues related to that work that they're doing that we might see pre and post disaster. Lastly, just a couple other points that I wanted to highlight here. Knowing and understanding the limitations on what it means to be in the industry and the work that they're doing. Sometimes in the United States in particular, we have a lot of conversations about how to prepare and how to respond to emergencies that are inaccessible to people for many of the social determinants of health reasons that we've talked about, right? Knowing and understanding not everybody has access to a vehicle, not everybody has access to resources to hoard materials or water or medications. And so knowing and understanding the limitations of that is going to be really, really important. Sometimes the environment that they're working in isn't meeting basic OSHA standards that might be ubiquitous across other industries in the United States. And so knowing and understanding that, one day when you've got the kind of relationship that you might be looking at in the future, there's the potential to affect that kind of change as you're thinking about having those relationships in places with large numbers of your patients as you start to communicate ways that their health and their well-being might be able to be better taken care of pre and post disaster as well. Next slide. Great. Additional considerations, as you all know, language is going to continue to be important. I'm preaching to the choir, I'm sure, but you all know as well as we do that even through translation, oftentimes the ability to communicate really important, complex, and detailed health and medical information isn't always the same and can sometimes be lost in translation. So making sure that you have volunteers or staff members that have the ability to communicate complex medical and preparedness conversations with your patient populations are really important. One of the things that we're going to talk about here at the end as well is, even when you're using materials, what resources are out there so that we can go out and make sure that they're in the languages of the people that we need to be able to do, and that they're built from the ground up in that way, of course. We know and understand that they're not always going to stay in the same place, so knowing and understanding where they're going, where they're going to be at any given time, as I can imagine you all, your schedule to make plans in and around hurricane season, if in the state of Florida in particular, is going to be key. I'm sure you do that for your families. I'm sure you do that for your clinics. That's going to be no different for a lot of the folks that you work with as well. Of course, knowing and understanding the cultural intricacies of the individuals that you're working with is really, really important because that helps you meet where they are and helps give you a better understanding of the kinds of conversations and preparedness that might make sense as well. What do they have access to? What do they not have access to, right? Driver's licenses, identification, the financial dependency. You all know this as well as we do. One of the hardest or one of the biggest barriers to accessing care sometimes is their inability to take off of work, right? That's a really key part of how they take care of themselves and their families. And so knowing and understanding that that's only going to be worse when disaster strikes, everybody is off of work or these things are isolated, that creates not only disaster-driven problems for them, but the potential of economic issues even more. And as we talk about knowing and understanding the disaster environment in the place that you live, we'll bring that piece up again. And then just to round that up as well, being creative and making sure you're taking into consideration the entire ecosystem as it relates to the kinds of environments they might be working in. You might have a really close relationship with one group related to one agricultural industry, but making sure you're knowing and asking the questions. This becomes really important too as you build relationships within your own community and understanding how to deal with those. Next slide. I apologize for the narrative heavy piece here. I want, especially as you get to take this stuff back and share it with some of your people. Some of this language and information is important. So thanks for bearing with me as I try not to read on any of this stuff, but it's important. I wanted to highlight just a couple of things from a disaster preparedness perspective as it relates to your individual clinic. Many of these feel like common sense, but there really is a science to emergency management. And I think it's important to share it with clinics in particular, because you're spending every single waking hour caring for the medical needs of the populations that you serve, and sometimes don't have the opportunity to take additional training or to go down the rabbit hole of understanding the emergency management cycle. But the other thing that I want to point out is that emergency preparedness and emergency planning looks very similar from the areas that you think about, but once you do that individual planning at your clinic level, it looks very different, right? It looks specific to your clinic and it looks specific to your community. So most importantly, and probably the number one thing that I'm going to point out here, is that when you do emergency planning and preparedness at your clinic, it's really important that you own that as a group, because you're really the only ones that can know and understand the needs of your individual patient population and the intricacies of your clinic and your community. So this, of course, always begins with that kind of risk assessment and planning, right? Going down that rabbit hole. You might have had basic conversations about the disasters and emergencies that might happen, but have you had that additional conversation about migrant and seasonal agricultural workers? Have you dug in? Have you mapped out this group or that group and the specifics to them? That's going to be really important. What are the vulnerabilities of the populations that we're working with, and what are we going to do about it pre-disaster, and what are we going to do about it after something happens? This, of course, all goes into the emergency response plan that your individual clinic developed. It's going to be important that you have local ownership of that for all the reasons that I just pointed out. And it's also important for you to go back and look at that every couple of years. I'm really excited for JP and Eunice to talk a little bit about their experiences, because I think what you're going to hear is that we thought a little bit about it, something bad happened, and we learned a ton during that process, right? As everybody does. The third area I would focus on is, what are those communication strategies? You know as well as I do that communicating with internal and external stakeholders, including your patients, is the most important thing pre and post disaster. There's some basic CMS requirements around what's expected about how clinics communicate with local authorities. But that communication, both with your staff and your volunteers, is going to be important in the same way that that communication with your patients post-disaster is going to be key. The last two areas that I'll kind of mention here before I keep going is both resource management and then training and exercising. Resource management, as you go through all of that planning, as you think about the needs of your patients post-disaster and the needs of the clinic, because I think as you walk through those processes, a couple of things are going to be important, right? Number one, the needs of your people. That's going to be your internal people. That's going to be your patients. And then the resumption of services. The quicker you can get back to providing healthcare to the people that you serve in a way that's conducive for them post-disaster is going to be most important. So there's a resource component to that. How are we going to manage clinic resources post-disaster? I'm going to encourage oftentimes for you to keep these conversations open with large-scale partners. A lot of you, right, work with MHP Salud on a regular basis in supporting your community healthcare workers. Project Hope is a resource for that, especially if clinics are affected by a disaster, whether it's supplies or manpower. Many of you have relationships with existing organizations that we consider partners, like AmeriCares or Direct Relief. That might be folks that you have opportunities to connect with to help increase those resources and surge those resources post-disaster. That's a really important one. Anna and I were on the ground in Florida post-Hurricane Ian for that very specific reason. Worked with a number of free and charitable clinics, federally qualified health centers, and including not only supplies, but providing additional medical manpower, as well as things like generators that could help them get up and running in a quicker way. Those are opportunities to continue to create relationships with organizations like Project Hope and others that could be there to support on a resource management side at pre and post disaster. And then lastly, I mentioned training and exercising, and this really goes back to the point I made a few minutes ago, in that, as you think about preparedness and planning for your clinic and the migrant and seasonal agricultural workers and other vulnerable populations, that changes every time there's a disaster. That changes every time the economy of your local area changes. That needs to be updated. Your staff changes, right? So think about just the amount of work that goes in every time you train and bring on a new staff member, and how often that changes. Is it once every 18 months? Is it every time you bring a community healthcare worker in, so on and so forth? Next slide. All right, last couple of kind of high-level conversations that I've already mentioned. Some of these are duplicates, so I don't mean to double, but just a reminder in the disaster preparedness context. Are we covered for all of those languages? Hey, we're really good in Spanish over here, but we know there's a group over here that might need an additional level of resources. Some basic questions. We know this group over here doesn't have access to transportation on a day-to-day basis. They might live on site. What plans, what conversations, what relationships do we have if we need to help provide transportation in or out, or even to access those populations post-disaster? These are all questions that you would walk through and think about as you're doing individual planning, and as well as some of those other ones that we talked about just a little bit earlier. And then the other big one that I'm going to end the presentation with today is this conversation about relationships and partners that you have. I'm sure all of your clinics have a ton of medical partners, whether it's local hospitals or additional primary care, other FQHCs. But do you have relationships with community-based organizations, folks who deal with the social determinants of health, some of those other things? What does your relationship look like with local food pantries, with emergency management, and everything in between? Every relationship, every conversation that you have thinking about this is a relationship and an opportunity to bring additional resources or help you access those patient populations post-disaster. Next slide. Oh, these are like the worst slides. They're so dense right now. I'll get to some more flashy pictures and stuff in a minute to help a little bit. Already mentioned some of this as well, knowing and understanding those language and communication challenges. And this goes all the way to not only basics around language, but of course around culture, around the diversity, around the access and functional needs, right? Is there a deaf population? Are there folks who may or may not hear your messaging? Is there a cultural sensitivity that we need to think about? And how do we use those and understand those pieces of what's important to that population and the people we're serving to bring into every aspect of the way that we're communicating disaster preparedness? And then, of course, as I would always suggest, right, how do you find those community leaders? Who are those formal and informal leaders within that cultural environment that will help you amplify and push that message? Especially those folks who already have communication methods and trust with those populations in the same way that your clinic might on the medical side. Next slide. I'm gonna just maybe highlight for a second and bring some more of the data that you shared with us in here in particular. And that's the training and education. This is a very difficult one to talk about because as clinics, you barely have enough time in the day to see patients, get people through, do your paperwork, do your charting, do that outreach, even the CHWs, right? Everybody's kind of overwhelmed. And so knowing and understanding that building a culture, especially in a place, where you live and work, is really, really important. So finding, bite-sized ways to be able to do that. How are you including in that in your onboarding? How are you including that in one-off seminars or lunches? Or are you running through tabletop exercises, right? And we'll talk a little bit about some resources for that as well. But how are you making sure that your staff members, your volunteers, as well as your patients are thinking about those kinds of things, because they can happen, and especially in a place like you live, they happen pretty regularly, right? And it's something that you want to think about. At the same time, you don't have to recreate the wheel on a lot of this stuff, right? There's a lot of community education initiatives. When I talk about first responders and emergency management here in a few minutes, I'm going to highlight that, right? Your clinics, you specialize in caring for people's medical needs. And that's what you do, and you do it well. There are entire groups of people who do community education around preparedness, around emergency planning, and are going to encourage you to tap into those, identify those resources, and find a way to tap into those things when you need them. And we'll talk about that here in a few minutes as well. And then finally, do you ever practice, right? That's another thing to think about. This is another hard one. It's hard to find time in the day. It's hard to find opportunities to do this. But think about, you could be as simple as a fire drill, right? That you're thinking about. It could be as specific as, hey, our emergency management group in the county is holding a drill today about a hurricane that's going to hit X, Y, or Z area, or a man-made disaster that might negatively affect the agricultural environment. Hey, we'd like to sit around that table. We'd like to listen. We'd like to learn what we can about the efforts of our emergency managers and the people who do this for a living, so that we can not only bring that back to our clinics and help inform our own disaster planning, but we can also tell them the perspective of the FQHCs and the clinics. We can tell them the perspective of this agricultural population that we've been serving for 20 and 30 years. We want to make sure you hear that perspective as you're drilling, as you're practicing, as you're building additional opportunities within the county level. And it won't come as a surprise to any of you. Sometimes the powers that be, wherever you are, or emergency management or administrations, don't always have the wherewithal and the perspective to think about any and everybody in their jurisdictions. Sometimes you all have a role to play in advocating for the needs of those populations, especially because they're going to be really heavy hit post-disaster, both from a health perspective and because a lot of the social determinants of health that we've already identified. If you can click it one more time, I just wanted to highlight some of the training needs that a lot of you already mentioned in the registration for this class in particular. And so you can see none of these will surprise you either, right? A lot of this was about how do we get additional training for our CHWs on disaster prevention for individuals, on communication and leadership, on emergency management and food and housing. And so this kind of where I want to end the conversation is there's ways and opportunities for us to kind of think about and to do that, that come from our local communities and a lot of the relationships that we build, and making sure that we know and understand how to update and provide that kind of education to our CHWs and our frontline healthcare workers across the clinic environment. Oh, back one. Oh, no, this is right. No, you're right. You're right. Sorry. All right, cool. Emergency management oftentimes is about collaboration and partnership. And so I'm going to kind of highlight two groups here for you. Many of you may already do this. You're going to roll your eyes and be like, Harley, I've already had relationships with a lot of these groups for 30 years. I know these folks, but I think it's worth bringing up the point, right? Access to people, support post-disaster, everything in this environment and in this business is about trust, right? Because we're in a people business, we care for people, it's about trust. So I want to continue to encourage you, if you've got large amounts of migrant and seasonal agricultural workers, making sure that you have a collaboration and partnership with those employers, with those agricultural environments. Sometimes that's possible. Sometimes I know that's adversarial. But any way that you can build trust will increase access, and be, helping to look at them as a partner, knowing and understanding the value that you're bringing to their working population, is going to be really important. So opportunities to be able to partner with them is going to be important. Next slide. Almost done, Shannon, I promise. We're getting there. The next one that you all may or may not be more tapped into is the kinds of relationships you might have with local emergency management or first responders. The beauty part is that that these groups are thinking and working on emergency preparedness and planning all the time. Your local health departments are going to have the same, a lot of the same things. They're going to have people whose job is working on public health preparedness around public health emergencies. And so partnering with them, finding out what tables they have. Are you part of the local healthcare coalition? Do they have local preparedness tables where not only you could potentially be, you could learn a lot, or whoever you send to those kinds of things could learn a lot, but that's where you build relationships so that you know who and where to call post-disaster, right? Hey, I want to check in on activities around water distribution. Is that being accessible into this area where I know a lot of my migrant and seasonal agricultural patients live and work? Oh, great. It's not? Great. Let's talk about how we can make that happen. How can we get the medical supplies, so on and so forth. Next slide. And just a really quick reminder for us that all response in the United States starts at that local level. So your relationships at that local government level, that local first responder level, that local government, that local jurisdiction is responsible for the public safety and welfare of everybody who lives in that jurisdiction. The state will come in to support that, and the federal government will come in to support that. So when I talk about making relationships with those local folks, that's why I say that. That's the nature of response here in the United States, and those relationships are going to be most important for you. How are you accessing those resources to care for your patient populations, and how are you affecting the plans and execution of those opportunities with them, with the perspective of your patients in mind? Last couple slides, you can actually skip this next one. Just like go 2 down for me, Shannon. So you've got some hyperlinks in here. We've got a lot of partners across the country, including Project Hope. There's a ton of resources out there, right? MHP Salute has a ton of resources. Our partners in the federal government have a ton of resources. Universities across the United States. I highlighted Drexel University's diversity preparedness website here. They've got an opportunity for you to go in, pick the language, and then you can see every resource that's ever been created in that language. The University of Minnesota did the same thing for COVID planning with any language you can think about. And so I just wanted to highlight some of those here. You'll get this presentation and you'll see hyperlinks there related to some of those things. But you don't have to recreate the wheel, right? Public health preparedness is a huge thing in the United States. Folks like Project Hope and others are working in this on a day-to-day basis. And so we want to encourage you to kind of tap into those resources and use what you can, because we know you're spending every single day thinking about the medical needs of your populations, and in particular, those migrant and seasonal and agricultural workers. I'm going to stop there, Shannon. I know we've got some time for question and answers. But as we always do, you're going to learn more from some of your peer clinics who have gone through this kind of thing, who have been able to implement response and procedure and preparedness plans for their own folks. And so really excited to hear more from them. Thank you so much, Shannon.
Thank you. Thank you so much, Harley. That was a great presentation. I know it's a lot to cover, and you did an excellent job covering it all in the short amount of time that you have. So with that said, I'm going to pass it on to our next guest speaker. We have Eunice Hines, who is the Director of Migrant Health Services and Outreach from Community Health of South Florida, or CHI. During Ms. Hines' 16-and-a-half-year tenure at the Community Health of South Florida, she has concentrated her efforts on serving at-risk populations in South Florida. In 2016, Eunice was appointed as the Director of Migrant Health Services with a clear goal to bridge the healthcare gap affecting the migrant communities and farm workers. She assembled the Migrant Health Services program by collaborating with a team of certified community health workers who promote CHI health services to the migrant, homeless, and underserved communities in order to ensure patients receive adequate health care and social services. In 2020, Ms. Hines' scope of responsibilities developed to include the coordination and oversight of outreach services conducted in a new state-of-the-art mobile medical van. And Ms. Hines currently holds a seat as a board member for the National Healthcare for the Homeless Council and for MHP Salud. And she serves as an active member of the Mobile Health Care Association, MHA, and functions as co-chair of the Florida Regional Coalition for the MHA. Ms. Hines truly embraces CHI's motto in her daily interactions and processes. Patient care comes first, and she's a true and passionate community health advocate. So with that said, I'm going to pass it on to you, Eunice.
Thank you, Shannon. I thought you had shortened that bio. But good afternoon. Great stuff, Harley. You really covered a lot of the groundwork for my presentation. So thank you. My name is Eunice. I'm the Director for Migrant Health Services and Outreach. And I am very proud to see a couple of my outreach workers also attending this presentation. Next slide. The one before. The one after this one.
I don't know why it's skipping it. There we go.
It's fine. There we go. Okay. So let's talk about CHI just a little bit. This is important to know because then you realize the passion behind everything that we do. The lady that you see in the picture is Doris Eisen. She is of Bahamian descent, an advocate for underserved in South Dade in the early 70s. And that's a picture of a trailer. This is how we all started here. She is the founder of CHI, and the story was that there was no healthcare facilities in the area, and babies were dying on their way to the hospital 30 minutes away. So it took someone with very little education, a migrant, to put a seed of love, of caring, and just to be passionate about making this point that we became who we are today, and we can't just forget where we come from with that. And we're here to serve all the underserved population, you know, within our service area. Next slide. And our mission is to deliver safe, accessible, compassionate, and cultural, competent quality healthcare services to the people of South Florida while training the next generation of healthcare professionals. And our vision is to become the healthcare provider of choice for the people of South Florida and a teaching center of excellence for healthcare professionals. Our mission and vision focuses on delivering healthcare while training the next generation of healthcare professionals to do the same. And we do this through our Teaching Health Center. We're also a site for community health workers to complete their 500 hours and get them ready for their certification with the Florida Certification Board. Next slide. This is our patient care comes first. It is our motto. And everything that we do, we kind of like follow it. You know, we reduce barriers because we need to, you know, be able to access, have patients access care. Everything that we do, you know, it evolves around in healthcare, in the way we screen them, in the way that we address this emergency preparedness, right? It's just to be able to make sure that our residents, both migrant, public housing, underserved populations are able to access healthcare within reach. Next slide. And geographically, we are right there where the little, well, actually one of the biggest stars down south of Florida, providing comprehensive integrated primary care, behavioral health, and HIV/AIDS services, and a teaching health center where residents in behavioral health care and primary care are able to practice this training, how it says in our mission and vision, the next generation of healthcare professionals. Also, CHI is one of the largest FQACs, in the USA of nearly 1,400 centers. You can see the little stars within the nation. Next slide. These are just some of our services that we provide: primary care, pediatrics, behavioral health, psychiatry and mental health, crisis unit, dental, diagnostic lab, diagnostic radiology, OBGYN, intrapartum care, optometry, pharmaceutical services and delivery, live scan fingerprint services, telehealth, translation, transportation, urgent care, and walk-in services. Next slide. These are some of our sites. We have 13 centers in Miami-Dade, 2 in which are located within migrant communities, over 36 school-based clinics providing healthcare to the young children, 2 mobile units, 4 pharmacies with medication transportation, 2 urgent cares, 1 imaging department. We have lab services. Transportation is free for our patients at any of our centers, 1 adult CSU, and 1 children crisis stabilization unit. It's under construction. Next slide. Okay, so here are the mobile units, the medical mobile van and the dental mobile unit. I oversee the medical mobile van, which is a 42 feet long, 10 feet wide, and 13 feet high vehicle. It was rolled out in July 27th of 2020. The dental trail is managed by the Director of Oral Health. The mobile van was developed with the idea to reach hard-to-reach location communities during our disaster preparedness, and boom, why not test it out during COVID-19, the pandemic. So the van was scheduled on a daily and weekly basis at different public housing communities within our centers. When the mandate to stay at home was put in place for many communities to reduce infection of COVID-19. So we were able to see patients right in front of their homes within these public housing locations. And we have learned so much from this initiative in having a health center on wheels in the community, and many ideas and opportunities have been put in place for the utilization of the medical van. And of course, not only to be used for during disaster or emergency situations, but also to reduce barriers to care and becoming accessible all year round in the community, addressing social determinants of health as well. Just to speak about the patient demographics thank you, Shannon. The overall organization utilization for 2023 was 74,637 unduplicated visits and 271,122 visits. Our patient demographic for the whole organization consists of a 67% Hispanic Caucasian. And then I'll start talking about the emergency plan. I also don't want to miss out from introducing my colleague, Mr. Kenneth Gould. He is the Vice President for Facilities and Logistics, who has also joined me. So in case you want to share anything, please, Kenneth, do jump in. But the emergency plan, what does your preparedness plan look like? So our manual is referred as COOP. The preparedness plan is a comprehensive emergency management plan combined with a continuity of operation, which addresses how the agency prepares for emergencies, activates the emergency plan, addresses mitigation and recovery of post-emergencies, both natural and man-made, such as hurricanes, fire, power loss, plumbing issues, air conditioner, and IT. And usually when we think about South Florida, all we think about, oh my God, the hurricanes. And so as I'm over here, researching and also looking into our COOP, not only to make sure that it's up to date, to make sure that I'm actually playing my part in my department, I'm realizing like there's just much more out there than what we really know when it comes to emergencies, right? So the plan addresses how patients and staff are notified, the preparation of facilities working with public safety and emergency departments, such as the local, state, and federal, both pre and post emergencies. It addresses all sorts of emergencies, staff training, etc. It details the duties of each department, communication, strategies, crisis management, security and safety protocols, and is reviewed and revised approximately every 2 years to ensure it meets accreditation and regulatory requirements. And so you would think that maybe for one center, this is a little bit too much, but it's actually, there's just so much that entails that we really do not know about, especially when it is not our department. So these are things that you learn. And as a team, as leaders within your organization, you actually put in place. And so imagine having 13 centers, right? And then you have 2 mobile units, and then you have staff in school. So it becomes a lot. So you definitely need to have that structure where everybody kind of like refers to the Bible, to the COOP, and know what to do when emergency strikes. So this manual helps us serve the community with minimum disruption, and the COOP guides our communication and action in the matter we deliver services. So this includes having contracts and memorandum of understanding with local agencies, such as a Department of Health, the fire department, the police department, county agencies, food agencies, supplies, fuel, HVAC for air conditioning, electricians, plumber, the FPO priority list. So when the lights go out, we get that VIP service, and they fast track us because we are a health center. Banks, you need to have that cash at hand, not only to be able to provide services to your patients and make sure you give them the right change, but also for your staff as well, because you don't know how long you're going to be without that access, to banks or electricity or whatnot. So in addition to transportation, the transporting of medications as well. So we have to maneuver or where we're going to put these medications from one location to the other. So a lot of things that happen that we are not aware, especially when we have nothing to do with logistics. We're kind of just doing our own thing within our own department. So Kenneth, do you want to share anything?
Thank you, Eunice. Good afternoon. And I just want to add something actually for Eunice's bio, because I was not there, but she just recently received the CEO award. That's an award that our president gives to the staff member who made the most difference in the organization and the community. And so, Eunice, you did a fantastic job talking about the COOP and the emergency plan. So I don't have a lot to add. I just want to say, a couple of things. Harley did a great presentation too. When you talk about the partnership and taking advantage of the local partners, I want to mention, for example, FAC, Florida Association for Healthcare for Community Health Centers. They do tabletops, they provide information. We all think that we might cover everything on the COOP, but when you attend these different sessions or trainings, you always learn something. I recently attended one that Yana, actually, I think Yana's here today, and she did a presentation when she talked about the rain bombs, which is, all of this rain that we've been getting, the past couple of years. That's a new term, so we got to start thinking about this. And obviously, this is a living document. You constantly are updating and adding information, so that helps you be more prepared and, ready for with your clients. But I don't have anything else unless you have any specific questions for us.
No. Okay, thank you, Kenneth. Next slide, Shannon. So how has your preparedness plan helped you better mitigate patient care during and after an emergency? So the preparedness plan provides the framework by which this, CHI, us, manages patient care. It's a plan of pre and post events, and this helps us in reducing confusion in messages and provides downtime procedures that provide continuity of operations and guidelines for both the patients and the staff. And just like Kenneth said, this is a living document that gets modified based on lessons learned. And based on those experiences, we keep updating our emergency protocol. So thank goodness for this, because I'm the type of person, I know protocol, but if emergency strikes and I'm just not mentally prepared for that, I will not know what to do. So having a plan and being ready and having all the tools, supplies, and addressing each scenario helps us with the bumps on the roads and unforeseen situations. And I'm pretty sure a lot of you are like that as well. So for example, we're able to partner with Ryder, like the truck company, which provides the PPE, groceries, to those patients being affected by an emergency to patient at no cost. So the items are dropped off at our designated center, and our health center becomes the location where community residents, the local ones, and even those that hear about it, they really come from long ways just to get, not just the migrant community, but just to get the needs, and we assist them as much as possible, of course. So we're lucky to have health centers within proximities in both counties where we can pivot in a short time, and the partnerships that we actually have, because we need partners and those community leaders to identify those community leaders that go, that got your back and your front and your sides. So when you pivot to brand new solutions that have not yet been tested. So that's very important, just like Harley had mentioned. Next slide. So how have past emergencies informed your current plan? Post-emergencies, the procedures that were carried out to activate the plan are critiqued with the goal of improving the procedures. And we have learned much about improving communication, specifically in updating technology to assist. And as you can see the pictures there, that's us actually doing registration those are the PFSS doing the registration, so that way we can do the COVID testing. You can see the signs right behind the staff. And at the bottom is our CHI medical mobile van. You see the tents, you see the chairs. And so everybody had to be kept at a distance, but we were helping individuals, you know, do their registration form so they can do the tests, so they can get their vaccinations as well. And so that's how we pivot everything. And that looks like we were actually at a warehouse, at a packing warehouse, doing those type of functions out of the centers. So let's talk about, again, the pandemic a little bit. We learned that we could do so much by providing healthcare from outside of the building. So before the pandemic, it was always a conversation, right? So here comes the pandemic and we had no choice. It kind of pushed us over the edge to really test these things that we had ideas, but we were not sure if we were able to do it. So now we had no choice but to be able to provide the services the best way we could. We became creative, and that's the word, just becoming creative. We had to use tents. We had to bring IT services outside to be used on tables, laptops, tablets, phones, while still protecting PHI. So we became health staff in pop-up clinics. We facilitated drive-through testing and screening, not just for COVID-19. We were like, what about our patients that still need to be seen by their doctors for the chronic conditions like diabetes, hypertension, cholesterol, right? So CHWs, and I really think that what the pandemic did was an eye-opening opportunity for community health workers to be notified and actually acknowledged for the work that they do, to be able to say, listen, this is what we actually can do, you know? So CHW commended staff that completed the screenings and testing for those patients that were allowed inside our health center. Remember that it was a mandate to stay home. So it was a time for us to grow, and we addressed, issues while reducing barriers to care, while we took care of our patients, our community, and of course ourselves and our families during a time that was very uncertain. Obviously, the IT infrastructure also had to be improved to be able to utilize our equipment out of the buildings, and while also protecting PHI, HIPAA, and cybersecurity all around us. So opportunities did arise plenty. Organizations such as the Florida Association of Community Health Centers asked CHI to be the hub for all other FQACs in South Florida, and we're housing portable generators and pop-up clinic or pop-up centers. As I envision it, these pop-up centers are like the kinds that the Army has, with the IT and the air conditioner and all that neat stuff. And I think that that's kind of neat, because had we had that then, we wouldn't be in those little white tents, which we had to buy a lot of those. But it was a moment to be proud of, the way we served the community, and how all the health centers, were able to kind of change the way they did the provided services in the community. So what can we say? Are we ready for the next epidemic? Only time and due diligence will tell, right? Because like I said, it's all about, applying learned lessons and keeping your COOP and your manuals up to date, and just having that communication with your staff and your department, and just having a vision that no matter what we do, we have to, provide the services to our patients. So patient care comes first here at CHI. Next slide. And so that's my information. So I'll take it away, Shannon.
Thank you so much, Eunice. It's so amazing to hear what your organization is doing, and I'm just really thrilled to be partnering with you on this webinar and sharing all of your information. I'm going to go ahead and introduce our next speaker. We've got Jean-Paul Ruggiero, who has more than 25 years of experience working in healthcare. He is currently the Director of Community Relations and Outreach at Healthcare Network. Prior to his current role, Jean-Paul served as the Acute Care Practice Manager at David Lawrence Center, where he had led the Crisis Stabilization and Baker Act Receiving Unit, as well as an inpatient substance abuse detox and residential Crossroads program. Prior to moving to Florida, he was the Senior Program Manager at Primary Care Development Corporation, overseeing its emergency management program for 9 years. He has a master's degree in public administration and emergency and disaster management from Metropolitan College of New York and a bachelor's degree in dietetics, food, and nutrition from Herbert H. Lehman College. Jean-Paul has published articles and presented at national conferences about emergency management. And we're so blessed to have you here. Thank you, Jean-Paul. I'm going to pass it on to you.
Thank you. Thank you. First and foremost, I would like to thank you, MHP Salud, for inviting us and putting this great event together. And I will be presenting more of a case study as to what was Healthcare Network's response to Hurricane Ian. More specifically, what was the role of the outreach department, more specifically, our community health workers. They were out, boots in the ground, and truly gathering data and bringing it back home. But without any further ado, I would like to just give a little background as to Healthcare Network. For more than 45 years, we have been providing primary health care to men, women, and children of all ages, and helping the underinsured, uninsured of our communities, as well as those who have the resources but recognize the quality of care. We are located in Southwest Florida, and it's worth mentioning that we're the only federally qualified health center in Collier County. We have over 10 clinics throughout the area, and additional sites are opening in the near future. We provide a multitude of services, such as, but not limited to, pediatric, women's care, specialty services, pharmacy, integrated behavioral health, dental, among other services. HCN also happened to have started from a mobile trailer back in 1977. I'd like to describe Collier County as a tale of two cities. To start, the city of Naples is known for its high-end shopping, world-class arts and culture, and sophisticated dining. According to Census Bureau data, Naples has a poverty line of around 7%, with pockets of agricultural workers residing in certain areas throughout Naples. If you ever had a tomato in the wintertime, it probably came from the town of Immokalee. And while the town is less than 50 miles away from Naples, which is incredible, right? It's just the distance, 50 miles. But Immokalee is one of the smallest and poorest towns. And basically, the population is around, the living below poverty line is around 24%. And HRSA has designated all of Southwest Florida as medically underserved. Next slide, please. Hurricane Ian was a deadly and extremely destructive Category 5, which was the third costliest weather disaster on record worldwide, and the deadliest hurricane to strike the state of Florida since the 1930s. Many folks lost their home, belongings due to the destruction that occurred throughout the region. As you folks well know, there was blackout and brownout throughout the entire state. And although Collier County did not go into a blackout, we did have rolling brownout throughout the area. There was pockets throughout Collier County where we did have total blackout. Next slide, please. As a health center, we closely monitor the path of the hurricane. Our executive team partially activated the ICS, Incident Command System, prior to landfall, and they were making the phone calls, reaching out to various organizations, our PCAs, disaster relief organizations, our community-based organizations in the area, faith-based organizations. I came in during the month of August, so I was brand new to the organization, and my new role was that of Director of Community Relations and Outreach. And sure enough, I had to fall back on my emergency management background, and I quickly did a quick huddle with my team. And one of the first things that I did upon hire was to review the emergency management program. I wanted to be familiarized with it, although I was not part of the emergency management committee. I wanted to know, because I knew that at the end of the day, if a disaster strike, outreach was going to go outside the health center, gather intel, and bring it back to the organization so that we can feed information to our executive team, hence our incident command system, so that they can advocate on behalf of the community, and most importantly, those who don't have a voice. So we were constantly gathering intel and sharing it so it can be escalated accordingly. Many of our partners call us within 72 hours after landfall. Our CHWs, we all got together and basically assembled and distributed care packages. These care packages had food, beverage, toiletry, hand sanitizers, and we had various community partners reaching out to us and saying, we have pallets, but we don't have the resources nor the manpower to mobilize them. I said, no worries. We have an outreach team. In addition, we also can pull in additional staff members from the clinics if needed. And sure enough, we did that. We gathered these resources. We put the packages together. A lot of these packages, care packages, we distribute within Collier County. However, Lee County was also having their own emergency, and they got hit much more worse than we did in Collier County. So we assisted a lot of our community partners in putting care packages so they can send it out to that county next over. Next slide, please. I think you skip, if you can, one behind, please. Slide number 3.
Sorry. Let's see if it's after that one. This one?
With the tent. One behind. Yeah, right there. Thank you. Our providers provided us with a list of vulnerable and high-risk patients post-disaster. And the first thing we did was that we needed to go and do home checks, see what's going on with these individuals, because they were already pre-identified as vulnerable and high-risk patients. We deliver medication, care packages. We link them up with social services and disaster relief organizations. During that time period, our specialty department piloted something that was known as, or is still known as, remote patient equipment, and our community health workers help educate patients on what are the remote patient equipment, how to utilize it, and since folks lost power, we needed to see what's going on with these patients because they're so frail and vulnerable. Next slide, please. Collier County Department of Health lost all of their tetanus vaccines post-Hurricane Ian. That's a major crisis at the local level. As you well know, during hurricanes, as a federally qualified health center, we were called to step in and assist and coordinate tetanus vaccination events to prevent potential infections associated with disaster cleanup. We mobilized our mobile unit post-disaster, and here we have a picture of our previous chief medical officer, Dr. Descherico, and she jumped into action with our outreach department, and she was providing a care out in the community. We also have a picture here where we have our director of behavioral health conducting a staff debriefing and reinforcing self-care. A lot of us CHWs, we were out in the community listening to all the disasters and what is it that family members and loved ones had lost, what they had gone through. And one of the first things that we did post-hurricane was to be trained up in psychological first aid. If your team has not gone through that, I would strongly urge you to link up with the proper organization so that your staff can receive psychological first aid. I think it's a great concept. And most importantly, your outreach team, given that they're going to be out there in the community and interacting with folks, and they're going to be hearing all of these crises that folks go through whenever a disaster strikes, for that matter. We solidify our community integration and collaboration with private and public agencies. So once again, we had built a wealth of partnerships and collaborators throughout the pandemic, but we never stopped. That is, we continuously engaged them and made them aware of what services the health center was providing. We also made them aware of what is the reach that we have throughout the community. And we also learned of their missions and services. So I would strongly encourage you to continue to foster that relationship. Both Harley and Eunice had mentioned the collaboration. If anything, continue to foster those collaborations and partnerships, because when disaster strikes, you don't want to exchange your business cards at that time. You want to do it well before, okay? Next slide, please. So ladies and gentlemen, the road to success is always best accompanied by others and not alone. By that, I mean, once again, work on the collaboration and partnership with community-based organizations. And let's not forget the faith-based organization, okay? And most obviously, our governmental agencies at all levels. My health center was in constant communication during Hurricane Ian with our PCA. So if you have not built that relationship and ongoing communication with the PCA, please do so. That's an extremely valuable thing to do. We launched an educational campaign to promote disaster preparedness in the month of September, which is National Preparedness Month. Hurricane Ian hit on September 28th. For the first time ever, many of our staff members were inquiring, what is a preparedness campaign? So it was a new concept. And I was really glad that I was able to bring something of value, not thinking that we were going to have a disaster, an actual hurricane within 28 days, right, of kicking this educational campaign. So one of the things that I would encourage for all health centers to do is actually kick off a disaster preparedness campaign, not only for the community, but for us staff members, so that we can be there and continue to operate as needed, as Eunice had mentioned. Do not wait for an emergency to review your actual emergency management program. And I like to say program and not plan. And there's a rationale behind that. I come from an old school of thought, and I'm sure Harley knows where I'm going with this. A lot of folks look at a piece of paper or a book and say, this is my emergency management plan. And it's just like incredible thickness of how thick that manual is. And the reality is, how much is staff going to absorb if your plan is that thick? So when you talk about emergency management program, it has to be not only the living document that is the emergency plan itself, but you need to drill and exercise and see what are the areas that need improvement. If you're high-fiving each other after a drill, something went wrong. Something went wrong, because there's always an area of improvement, no matter how minor it is, okay? And I know that CMS says you should review your emergency management program within every 2 years. I would say every time there is a disaster, look at the emergency management plan and update it as needed. Perfect example, one of our health centers, known as Friendship House, got flooded during Hurricane Ian. And sure enough, in our emergency management program, we already identified a drop in the box. What is a drop in the box? Basically, the health center was shut down, but we were able to drop a box, a large box, and staff were able to see patients inside that box. So it was part of our emergency management plan, and sure enough, it did work. Once again, capture everything that occurs. Immediately post Hurricane Ian, we did a debriefing a couple of weeks afterwards. I did it at week 1, and we did it at 1 month post disaster. And basically, we wanted to capture certain things immediately after the disaster, and we knew that it was going to be a prolonged period of time. So I wanted to do another debriefing, and usually that's known as the hot wash. And basically, as a department, we put everything together, capturing what went well, what are the areas of improvements, and what are the recommendations, so that our incident command team can look at their emergency management plan, the much larger plan, and see what needs to be worked upon. And without any further ado, next slide. Thank you so much. I wanted to make sure that I keep it within a certain time period and leave for some time for Q&A as well.
Thank you so much, JP. What a great presentation. And your organization was so blessed to have you at the right time, it sounds like, with all of your training. Thank you for sharing your efforts around, responding to Hurricane Ian. I'm sure a lot of folks here were able to, really look internally at maybe what they can do to continue to improve. So thank you. I'm going to pass it on to my colleague, Monica. She's going to discuss the CHW role in emergency preparedness real quick, and then we're going to go ahead and open it up for Q&A. So please do put your questions in the chat or Q&A box. Monica?
Hello, everyone. Thank you so much for providing me this time to share. And so I'm highlighting the CHW in action role more as a resource and a call to action. So as Shannon mentioned, I'll be touching on it briefly, but the information is there for you to go ahead and implement it. One of the things that I want to create additional awareness, I love how every one of the presenters brought on so much to share. And so now we think about how are we going to take out all of this information out to our community and have real-time discussions, address issues that maybe they're not able to share during the emergency. So we want to think about how we're going to incorporate CHWs and highlighting on all of these qualities and skills that they have. Next slide, please. So as you see, CHWs can be integrated in diverse roles because community health workers are recognized as trusted members of their communities. We have boots on the ground within our communities. And here you'll see one of our CHWs out and about in the community during the pandemic, actually out in the field, providing information to migrant seasonal agricultural workers. And so we take on different roles to be able to connect to our communities, create that trust that connects to health centers, that connects to emergency preparedness, that connects to all of the other individuals that will be able to bring all of the awareness and knowledge to be able to prepare for emergency preparedness or disasters that strike. Next slide, please. Again, just to touch base and highlight some of the skills and roles and sub-skills that CHWs have and can be integrated into promoting emergency preparedness in the different phases, is taking into consideration the culture, the coordination, advocating, making sure CHWs have a seat at the table while you're doing emergency preparedness. Why? Because again, we take back the message in plain language. We're able to address issues, fears, connect them to real-time support. And also we take into considering that mental health aspect of what's going on, not just for the community, but for the CHW role. I love how you mentioned self-care. CHWs demonstrated a lot of resiliency during the pandemic. So it's a dual role. We give a lot of the support, but CHWs also need that support as well. Next slide, please. Okay, and so these next 3 slides are the ones that I will share as a resource for your reference. One of the things that I would definitely like to highlight is that as community health workers, we're able to start, again, the process rolling pre an emergency, again, by ensuring that CHWs have a seat at the table in all your planning committees, in the coalitions, also within maybe even the assessment process of what did go wrong or what could be done better. Again, remember, we are the ones that are having the conversations real time with the communities. So bringing back very key information to the organizations can definitely help catch some of those things that could have done better, didn't work, did not work, or maybe even the community has a plan for action that they themselves have been thinking about. So that engaging process in integrating the CHW throughout the during, and post is very crucial. Again, I'm sharing these slides as a resource. If you have any questions or comments, or would like to reach out to MHP Salud for any further support, please feel free. I want to make sure that I leave time for questions and any comments. And so I'm going to go ahead and pass it back to Shannon. Thank you for providing me a little bit of time to share the role of a community health worker. Again, I know it was already shared prior, but one of the wonderful things that we do is that we connect to the community before, during, and after. We're able to have those one-to-one discussions, and we're able to be trained for specific population needs and situations. The resiliency and role of a community health worker is just amazing. And I thank you all for thinking about how you can better emergency preparedness plan by preparing your staff and community health workers as well. So thank you.
Thank you so much, Monica. What a great point. And none of this would be possible without our outreach and frontline staff, including CHW. So please keep those individuals in the conversation throughout your entire emergency preparedness plan and implementation and evaluation. I have some additional resources here. There was one question I wanted to take a moment and open up to the speakers or anybody here in the meeting. Jack mentioned that he was often struck by how services and MOUs stop at state borders. Are cross-state agreements pretty common nowadays so that communities don't fall prey to being isolated on state border that would be better served by a nonprofit potentially across state lines? Not sure if any of our speakers can speak to this, but also I'm going to open it up to anybody present here to answer as well.
Hey, Shannon, I'll speak to that a little bit just to maybe highlight a point that a couple of us made, and that's that each jurisdiction is extremely different. And we have a lot of experience in deploying medical volunteers into different states post-disaster. And each state, almost per disaster, right? As a part of the disaster declaration that's often made by the governor, it will include language that will allow for or exempt medical providers, right, who are licensed in one state to potentially come in and operate in another state. So that language is really important, and knowing and understanding what that looks like in those cross-border communities is important. And so there's some work you can do on the front end, right? What does that language look like traditionally? What did it look like in the last disaster? But also knowing and understanding who to ask that question when that disaster comes out, to take a look at that. But if you're, often maintaining those kinds of relationships on both sides of the border pre-disaster, you might be able to get a better handle on what that looks like and what is possible as well. So again, I know that's kind of a long-winded answer, only to say that it is very jurisdictional, and there is opportunities for that kind of opportunity to happen, especially when a disaster happens.
Thank you. I am going to share the link here in the chat to the evaluation. You can also access it through this QR code here on the screen. Please take a moment to evaluate our webinar today. It really helps us provide a good TA to you all. Thank you for being here. And if there are any questions, please do feel free to reach out to any of us. I can relay your questions to our speakers if you have anything specific to them that we didn't get to touch on today. All of the slides will be shared, as well as this recording, via email in the coming days to all registrants and participants. So you'll also be able to access it on the HRSA Health Center Clearinghouse. So thanks everyone for coming today. Thank you so much to our speakers. What a great webinar, and I really appreciate everyone, and have a great day.
Thank you.
Thanks. Bye-bye.
Thank you.
Thanks, everyone.